Hello everyone. We'll be going through this lecture today. We've got the little chat box below. If you have questions, you can type them in there. We can try to answer them as we go, as well as right at the end. So without further ado, we'll get started here. So the way this lecture will go, we'll go through some of these questions, go through the explanations, and then go through some of the anatomy approaches and some of the thinking behind why some of these questions are correct and written as such. So with this first question, we have a 32-year-old female involved in a motor vehicle collision with a right hip dislocation. She's 12 weeks pregnant. No issues with the baby via ultrasound. Undergoes closed reduction of the hip and is unstable. Post-reduction film shown in Figure A. What is the next most appropriate step in management? With these, we have, as with any of these questions, 5 options here. So exam under anesthesia and then ORIF, non-weight bearing for 6 weeks, skeletal traction for 6 weeks, fetal monitoring until 15 weeks, and then a delayed fixation, so that would leave her 3 weeks after the injury, and percutaneous pinning. Just being a test-taking expert as you all are, you may be able to start eliminating some of these options here. So figure A shows a right-sided acetabular fracture, pointed out here by the arrow. Drag it over. So we can see a posterior superior acetabular fracture. We can see it better in figure B as we have our obturator oblique, and we can see some subluxation of the head. So this is an injury that should go in traction as the question described. So after going in traction, the correct answer is exam under anesthesia and open reduction internal fixation. This does meet criteria for undergoing open reduction and internal fixation. The pregnancy itself is not a absolute contraindication towards proceeding with surgery here. Skeletal traction for 6 weeks typically is not utilized, especially in a high-risk patient such as this. And again, percutaneous pinning and non-weight bearing for 6 weeks also in an unstable hip are incorrect. So the one thing you'll notice on the following questions coming up here, an emerging topic on the exam under anesthesia, and what that is, we'll go over in the next couple slides, but it's very a big press towards this on a lot of the upcoming tests here we've seen over the last couple years. So when in doubt, if you're not sure if this is stable or not, and the EUA is a possibility here, it's probably a good choice. So the next question, we have a 14-year-old who presents for evaluation of her left hip. She had workup regarding her abdomen, and this was negative. The pediatrician obtained a X-ray, found abnormal radiograph of the left hip, and requesting evaluation per U. Left hip is shown in figure A, asking about what is this abnormality here. So we have a 14-year-old with a posterior superior area that are concerned about fracture. These are very common. It's well demarcated there. Looks like an old lesion. And what this is here, 97% of you got this correct. An os acetabuli, an unfused area that really is not an acute fracture. Generally, these patients are not painful and really only have, this is an incidental finding here. Most of the time this fuses by age 20, but again, this can exist into maturity as well. So now into the bread and butter of this. Acetabular fractures really are split up into 2 areas here. So this would be high energy for our young patients doing silly things, or low energy for our old patients with osteoporotic bone and falling here. The can be associated with about anything here, as you can imagine here. Low extremity injuries are the most common, especially due to the association of acetabular fractures with motor vehicle collisions. The fracture is determined by the position of the femoral head and the direction of energy at the time of impact there. So if the head is flexed up and your hip is flexed up, you can imagine the direct force is going to go more out the back, whereas if your hip is extended, the force is going to go forward, and you tend to have an injury more in the anterior column or anterior wall. The older we get, obviously the more comorbid conditions you have, as well as worse bone you have, so you're going to have worse outcomes here. And then the rest of the poor predicting factors generally revolve around the quality of the bone and quality of the reduction itself. So the next question on this, we have a 32-year-old male sustaining a posterior wall acetabular fracture as a result of an MBC. Improved patient-reported outcomes are associated with which of the following variables? And with these, again, we can imagine the older we get, the bone is going to be worse. Probably not a correct answer here. Increased hip flexion extension arc is a possibility. The more flexible you are, the happier you're going to be. Immediate weight bearing after most acetabular fractures isn't possible, so especially for a posterior wall, it might not be the correct answer. Increased strength, stronger people are happy, and decreased stride length, probably incorrect. So with this here, some of this question in particular gets down to knowing the particular article here, but it is increased strength. And with this, again, stronger people are happier, you can compensate more. It doesn't go into anything about the quality of the reduction or quality of the bone here. So again, some of these questions really focus on just knowing one or two facts instead of knowing and trying to sort out everything, which is the most important. Well, that one's a little hard to read. And so the idea of the column theory of the acetabulum is really best shown with this inverted Y here, where the acetabulum is a cup seated in between the two limbs of the Y here, connected to the sacrum or your axial skeleton through this thick column of bone, your sciatic buttress. This normally has a little bit of give to it as you ambulate, but is really what the whole classification scheme is based upon. So definitely know that picture as well as these ones coming up here. These will be tested. So the anterior and posterior column, in green here we have the posterior column highlighted here. It's composed of some of the quadrilateral surface, the posterior aspect, the posterior wall, posterior dome, some of the rim associated with that, our ischial tuberosity, ischial spine, as well as all the way up towards our greater sciatic notch, which is shown right there. So great quality bone, and again the posterior column. Remember, the pelvis is tilted forward, so if you're looking at a pelvis or pelvis model here, this is something that you have to tilt forward. It's not just a something staring at from an AP plane. The posterior column, again shown here, move this arrow, is the back part of the pelvis. So in a radiograph or a CT, depending on the obliquity here, you may be able to see some of the posterior column as I put the arrow right there. The anterior column now is the rest of this. So everything in this bluish purple color is the anterior column. So this goes all the way up to our iliac wing, which is why if you see a fracture up there, generally it's an anterior column or something related. You have our anterior wall, our anterior dome, our iliopectineal eminence up the front, as well as some of the parasymphyseal region shown here. As we rotate the pelvis, now you can see the purple here in a better 3D model, where it's the entire front of the acetabulum going into the pelvis. The corona is something, again, this is one that will be tested over and over, as well as if you're in these surgeries, something to definitely watch for, hence the scary name. It's an anastomosis generally of the obturator vessels and your external iliac vessels. Every once in a while this can come off the inferior epigastric as shown in this particular model here, but often and most tested is off the external iliac vessels here. And as we use the stop approach in particular, dissecting laterally from the symphysis, we have to evaluate for these vessels, and these can be quite large and fatal if ignored. The classification scheme is something easy to remember, sometimes hard to picture or try to turn a particular x-ray or set of CT into which classification it is, but that's we'll get over. So these are things we have to memorize. We have 5 elementary we'll start off with. All of them involve one column except for the transverse pattern. So we have our anterior wall, our posterior wall, our anterior column, posterior column, and then a transverse, which is on the far right, and you can see this is the only elementary pattern that actually crosses and goes through both columns. Our associated patterns, you can think of these as the more advanced or more comminuted fracture patterns. The both column, kind of thought to be sometimes the granddaddy of them all, this particular figure is not correct, I'd just like to point out, so hopefully you guys will notice that. So where I drew the green arrow there, you still have a small piece of acetabulum connected to the axial skeleton. So a both column fracture by definition is just that. None of the axial skeleton can be connected to the acetabulum, and so here we can see on this particular figure by the artist, unfortunately we still have a little bit of that left, so ignore that. The next one here is a posterior column, posterior wall, where the posterior column is involved, often with a transverse line as it exits posteriorly along with an associated posterior wall fragment. Transverse posterior wall is the most common fracture pattern of the associated type and seen there. The fourth one over here, an anterior column, posterior hemitransverse, is a very classic pattern seen in the elderly, especially with osteoporotic bone. It's associated with medialization, and many times these are treated with ORIF and even arthroplasty. T-type fractures also are no fun to necessarily deal with at times. This involves both columns. The columns rotate independently. If you see a T-type on your test, think about possibly doing dual approaches or even a extended approach for something like this. So here's my way how I figure this out here. So the classification, now you know which of the 10 types, and hopefully you can recite all of those. First question is what columns are involved. If we figure out which columns are involved, anterior, posterior, we can narrow these down quite a bit. Is there any separate wall involvement? And the in-training has got you on looking at a transverse fracture pattern and not following all the cuts and realizing that it's not a posterior wall but a transverse fracture. So we need to look at any separate wall involvement. It can't just be the exit line of a particular fracture, a main fracture fragment like a transverse pattern. And then number 3, like I mentioned, the definition of a both column is any articular cartilage in continuity to the axial skeleton. If the answer is no, then you can really ignore steps 1 and 2 because you know it's a both column injury. And then we get to the visualization of these. How do we figure out what columns are particularly involved? And so this question from 2012, the posterior wall of the acetabulum is best visualized which of the following radiographic views? So we have inlet, outlet pelvis. You should know those are more for pelvic ring injuries. We have an AP pelvis, which is helpful and usually one of the trauma films we obtain. We have an obturator oblique as well as an iliac oblique. So whatever your mnemonic to memorize this is, just stick to it. Or if you can't remember anything, just try to get a pelvic model or even picture in your head which way you have to turn the pelvis to be able to see this here. So Iowa was the one I learned, iliac oblique wall anterior. Probably have better ones out there, I'm sure, but that's what I stuck with. So this answer here is obturator oblique pelvis, and we have some pictures of that coming up, but as it opens the area, just like that CT model we showed before, it shows that you can see some of the posterior wall just through that particular view. An AP pelvis, again, we always get, it's nice to compare that to the other hip. Obviously the iliac oblique is the obturator oblique on the contralateral side and vice versa, so you can compare those, but a standard AP is easy to understand and should be obtained in the workup of all of these patients. So here's a CT view first, a 3D CT reconstructed view, a Jude view, looking at an obturator oblique. So on the patient's left, this is an obturator oblique. We can see our obturator ring nicely shown there. So if you can't remember which one is which, just if you can see the obturator foramen there, then that's the obturator view. On the patient's right side, as I draw here, the iliac, the whole ilium is seen, and so that'd be the iliac view for that side there, which is nice and easy to see. So if you can just remember this, you can kind of figure this out. So on the patient's left here, as drawn on this red line, that's the anterior column we can see, and then our posterior wall. And as we look on the contralateral side here on the patient's right, if we look through the pelvis, we can see the patient's posterior column sitting right here and some of the anterior wall right there, as well as the ilium. And here's an x-ray view, which you're probably more used to seeing here. We drew out the lines for the anterior column as well as some of our posterior wall right there. And here's the contralateral side, which you notice is just different lines drawn on the same film. So the patient's lifted 45 degrees one way or the other, and that's how we obtain this here. You see the posterior column as it's going back towards the sciatic notch, where I have the green arrow there, and then we can see our anterior wall right there. This also gives a great view into the iliac wing, looking for any high extensions of any anterior column fractures. And there's our 3D CT representation, just turned that way to take a look at the patient's left hemipelvis, showing the posterior column, anterior wall. Looking, the iliac oblique will also sometimes better show you the internal, the medial wall of the acetabulum and kind of show any fracture lines there or any protrusio. Next question, a 35-year-old male undergoes closed reduction under sedation in the ER for a posterior hip dislocation with an associated posterior wall fracture. Most of you should have seen this as a very common scenario. The post-reduction CT is shown in Figure A. What is the next appropriate step in management of this injury? So a CT scan is excellent for looking for any intra-articular fragments, looking for any marginal impaction, and then as well as evaluating the size of the acetabular wall. If it's something that's too small, too big, we can go back into the exam under anesthesia, but it gives us numbers to work with. So again, what is the next step in management of this injury? We don't know what the CT shows, so it's kind of hard to even look at that. So let's load that. So we can see the patient's left on this axial CT shows a posterior wall fracture here. Some of the newer test questions have an entire series of CT where you can scan through these, which gives you a better picture or idea. It also brings up the complexity of knowing where to measure some of these. So with this here, it's a relatively small fracture. We can use the contralateral side over here as a nice template, since the CT is obtained and really isn't is fairly perpendicular to the patient's axis there. So the side to side, these are pretty symmetrical. So fairly small, and remember what I explained before is on tests, as of recently, this is a thing they've been stressing about exam under anesthesia. If you can't measure it out or don't have a way to measure it to give you an absolute number where it's a very, very large fragment where you know you need to fix this, then exam under anesthesia is the appropriate thing to do, because this doesn't look at a static image in time. This looks at the dynamic function of the hip as well as the stability of that piece, and more importantly, the femoral head staying in the acetabulum there. So the stability, as it mentions here, is critical for success of non-operative as well as operative management of any acetabular fracture. So if we can't show that this is a stable injury, it's probably going to do better if we stabilize it by fixing the posterior wall there. Going back to your views, it really is using the same views as what you did before. You're trying to axial load, internally rotate, and adduct the limb as you're loading this, and look in the obturator or oblique view, looking for any displacement of that posterior wall, and more importantly, subluxation of the femoral head. You usually see an increase in medial clear space if it does want to open up. Next question. A 34-year-old male is presenting with a right posterior wall acetabular fracture shown in Figure A. What is the most accurate method to test for hip stability in this patient? Should be a gimme after what we've gone over already here. Again, we've got a axial CT, which is nice to help show us the size here. We don't know really if this extends cephalad, caudad, or is just an isolated little tiny piece there. So if we don't know any information, we go with dynamic fluoroscopic evaluation under anesthesia. 96% of you got this correct, so I think you guys are catching on to this here. The traditional teaching is shown there where less than 20% of the posterior wall is generally thought to be stable, where over 40% of the acetabular or the posterior wall, if fractured off, was thought to be unstable. However, it's been shown that the exam under anesthesia is much more sensitive to detecting any of that instability there. Additional views here. On the right, you actually can see dynamic loading of one of the stress tests with the image on the right. With the arrows drawn here, you can see some of the clear space as that joint is being loaded, and then where the green arrow is now, you can see the posterior wall moving compared to the middle image here where it hasn't been actually loaded yet. An AP image on the far left here with the green arrow shows that posterior wall fracture. However, the joint looks pretty well. You can imagine detecting any instability or movement in that plane is going to be much more difficult or require a lot more instability rather than having an appropriate image showing and focusing on that posterior wall and watching that move. Again, I mentioned for this here, there's no absolute limit or how much you're supposed to put on there besides enough, so admittedly it's pretty vague, but flexion, adduction, axial load tends to open that up if it needs it. Acetabular landmarks, if any of our residents here online, they know that these are things we start off with as an intern and really tell you how to read a pelvis. If you don't know your lines here, you can't tell really what's fractured. You can learn a lot from an AP image, and that's what we have here. So we'll start out, anytime you read any of these AP pelvises should be really systematic. Generally, I start from the top down, looking at our lower spine. Is this connecting? We can look at, for any abnormal sacralization or lumbarization, we can look at our SI joints in the back. We can look at our iliac wings on both sides, and then as we work on down, we can look for any foreign bodies even. And then we get down into the pelvis here in the acetabulum. So I'll draw on this line here our iliopectineal line, which comes on the, looks more cephalad surface here on an AP film. That's looking at our anterior column. And then as we go down, this line that's more vertical along here is our ilioischial line, and that indicates our posterior column. And by that we mean if there's a break in that line, there's a fracture in that column. So you can tell a lot even if you see a break on an AP even before you get your Judet films. We have our dome of our acetabulum, which is pretty easy. It's the top of the acetabulum. We have our teardrop here, which is essentially just a confluence of lines. And then we have our anterior wall, and then our posterior wall here. There can be crossover, which you may go over in some of the other lectures and other web pages on here about impingement. This here, Shenton's line in there for continuity. Essentially, in pediatrics, more important, but in adult, essentially looks for the hip being concentric and located. Roof arc measurements traditionally are thought to be 45 degrees here, and what that is, you take a line from the center of your femoral head on a adequate AP, draw a line straight up, and then you draw a line from the same point on the center of the femoral head to the fracture line. If this is within 45 degrees, so meaning less than 45 degrees, then your fracture of your acetabulum exits through the weight-bearing dome and generally meets operative indications, also just because this is more of an unstable pattern. The roof arc measurements can't be measured on your both column fractures, since your both column fracture often or can have no fracture lines exiting into the acetabulum where it's going to be able to be measured. Also, posterior wall fractures are just essentially an enlarged rim, so those involve the posterior aspect of the joint and really can't measure on these traditional films here. Essentially looks more for column involved fractures. The younger the patients are, they tend to have traditional patterns here. With this, it'd be posterior wall, often MVCs, any load actually on the knee as they're hitting a dashboard, falling off of anything on their knee, and so on. As their leg is more abducted, you can get any of the transverse fracture families here, whether it's a pure transverse, transverse posterior wall, or even a T-type fracture. As we get more elderly, the reflex answer here in somebody with bad osteoporosis would be the anterior column posterior hemitransverse fracture. You get a lot of medialization of our wall with protrusio of the head with that. You can also have both column fractures, and oftentimes these have to be diagnosed with CT because you can have fracture lines going everywhere in this osteoporotic, poor quality bone. Next question, we have a 27-year-old sustaining a fracture dislocation of an acetabulum, pelvic radiographs. The first two are taken at presentation, and then we have a CT after reduction of the hip in the emergency room. What's the importance of the finding highlighted in the CT scan cuts? So again, we get a CT to look at bodies in the joint as well as marginal impaction, and then to assess our fracture lines. So assuming we're reduced here without looking at these here, we can kind of go forward, and so we have figures A and B are the radiographs, and then we go figures C and D. So this question here is asking just about the CT cuts. So you can use A and B for a diagnosis, and then figures C and D to really answer the questions here. The nice thing about this is they highlight it for you, so I don't even have to draw my arrow, but I'll be a nice guy and do that there. So we have a superior impaction as shown on figure C, and then D, we can see this impacted piece here obviously is not concentric with the hip. We also see through the rest of the C, there's either the edge of a fractured piece or some fragments as well. So we worried about the impaction quite a bit, and you can get a hint of that on figure B, where the femoral head looks subluxed, as this impacted segment where my arrow is there usually portrays a poor prognosis, and we can see this posterior debris, whether it's large pieces or not, also as a result of their injury. So it goes back to significant marginal impaction could compromise the results of reduction of the joint if it's not properly restored, which makes sense. If we don't have a concentric hip, the patient's hip is going to do much more poor. And common posterior wall fractures, we probably see this more often than the superior impaction, which is often more hard to treat, especially as that gets more medial. But posterior impaction with a posterior wall or transverse posterior wall fracture pattern is fairly common here. And the reason why we pay so much attention to that is we need to restore how concentric the hip is there, which means we need to elevate and lift up that aspect of the joint back into position and use the bone graft, whether it's autogenous from the ipsilateral trochanter or whatever your graft of choice may be. For imaging for these here, the CT scan is the gold standard. With this, the Judet films, often surgeons can get quite a bit from this here, but the CT scan can get more information like I mentioned before here. In most trauma centers, this is part of the trauma workup, so it's information readily available as well here. This can be 2D and axial like the one shown here, or you can get this in 3D and you can rotate this around, which helps plan surgery, especially if you're not used to going through the 2D cuts. CT scan helps look at the fracture pattern orientation as well as the size. We've already seen that where they've kind of hinted around the size of the posterior wall and the importance of that. And then I mentioned the other important ones that a CT can show that the other ones that a plain film can't. Marginal impaction and loose bodies. This should be roof arc measurements. Remember, we mentioned 45 degrees if you're measuring on a radiograph. If you're measuring on a CAT scan to look if the fracture goes into the dome or weight-bearing surface of the joint, you need to figure out how thick your cuts are. Generally, they're 2 millimeters, and then count your number of cuts down from the top cut of your dome. So that would be 5 cuts, and then a fracture line exits within those 5 cuts. That means that the fracture exits the dome, exits the weight-bearing dome, and is going to be unstable and usually meets operative criteria here. For hip fractures, 2 millimeter incongruity is the magic number for this joint as compared to many other joints in the body which also have the arbitrary 2 millimeter mark. Doppler ultrasound, probably not going to use. You'll see a lot of patients like this. There's a lot of soft tissue to go through there, so you'd have to have a powerful ultrasound to do the job. So in the realm of acetabular fractures here, you're really only going to use it to evaluate for DVT. So here's this again, just shown to reiterate the importance of knowing this classification inside and out, because you're going to be tested on this, as well as probably see some of this in real life, maybe no matter what you do. You may not treat them all, but at least you'll be able to recognize it. Remember, or if you're just joining here late, this both column figure is incorrect. The posterior superior rim of the acetabulum here should not be connected to the axial skeleton, so the red line here should actually be drawn above. So other than that, these figures are right as far as I'm concerned, and again, try to remember these. The anterior wall is a pretty rare bird here. We don't see it very often. Oftentimes it actually is overread by the radiologist as more of a pubic root injury. And so what I mean by that is where the acetabulum meets our pubic rami here in the front. So we can see a fracture line like this where it does exit into the anterior wall, but oftentimes we can see these exit more medially into the rami, and it's actually part of a pelvic ring injury just with a fracture line exiting the acetabulum. So again, having a true anterior wall fracture is pretty rare. Most of the time it's actually a pelvic ring injury. The posterior wall, as I mentioned before, is the most common just because the ways you can break your acetabulum, your hip is usually in the flexed position here with an axial load directed posterior. We can see there's a little posterior wall disruption. Hopefully you guys know which of the views to get after this here. So if a posterior wall is fractured, oftentimes we have a hip dislocation if the piece is big enough or the energy is enough to continue with pushing the hip out of joint. Here, now we can see our obturator oblique. We can see our posterior wall disruption here. It can be hard to see sometimes, especially if it's not really displaced, but oftentimes in hindsight, if you don't see it and you only see it on the CT, you can go back and find it. Here is one that's probably more common. We can see our femoral head is subluxed posteriorly. The posterior wall is essentially missing. The surface here is turned 90 degrees or so from the original position of this, so this is impacted, would need to be lifted up, and then we can see some of this back here. So if you see a lot of these, you'll have to find that piece because it's not necessarily always in the same cut as where it used to be. So helpful by scanning through or using a 3D CT for that. The anterior column is one more associated with elderly patients fall from standing onto their hips, so some of the patterns where they may break their femoral neck or break their inner troch area, this could be something can happen as well. The anterior column, remember, it does extend up into the iliac wing, so if there is a fracture exiting high into here, as well as the acetabulum, it does involve the anterior column. These figures don't always get hung up on where these points exit because they can have some variability as well. It's nice if the fractures all read the book and the diagrams, but they don't. So remember, if it goes up into the wing, it involves the anterior column. Here you can see here, so this is one, just like I mentioned. They love to exit way up high here, which is nice because these ones aren't that bad to fix, and it exits all the way down. Here we can see towards the medial part of the acetabulum, at least on this view, and then we can see this as it exits there. So this would be a good one to get our obliques on as well as a CT to make sure it doesn't go anywhere else, but at least from that one view you can tell it's anterior column. The posterior column is just the other side. Remember, it's the back side here that goes towards our sciatic notch, doesn't exit anywhere in the front. The fracture line here is close to the superior gluteal neurovascular bundle, and with displacement of this particular column, it can actually entrap the vessels in that fracture fragment. So something to see on the CT scan, especially if you have a CT angio, you can sometimes see the vessels pinched in there. You want to know that ahead of time, otherwise you're going to potentially kill the patient. So not a good thing. The plain AP film here, thing that gives this away for me is looking at the notch here, seeing the asymmetry here. You can see the fracture of the posterior column actually goes all the way pretty high, right almost to the notch there. So the fracture line here, I would be worried about having that neurovascular bundle involved. There we go. So you can also dislocate with an isolated posterior column injury, but again, more primarily, it's going to be a posterior wall associated with that, and that lets the head out of the barn. The same views here, we can see our anterior column coming up here, so this is intact. Again, you can verify this on a CT, but with an intact iliopectineal line, more than likely you have no anterior column involvement. And by that, and looking at our other views, we can see that the posterior column's involved. We can already eliminate some of the choices from our group of 10, as you already memorized. So here's this side here, looking at our iliac oblique and our attempt at that. We can see that line. Again, they gave it away to me at the beginning, the fracture line in the notch, and the whole column is off from its home, which would be right up there. Our anterior wall, admittedly on this x-ray, maybe not be the most clear, especially as it's going through the internet here, but you can take my word for it, the anterior wall is intact in that particular view. And here we go. So again, an axial CT, get to know these here. The position of your fracture line through the acetabulum will tell you a lot, even just on one cut, according to what it's doing there. And there has been some questions on that, looking at the pattern, whether this is a transverse or a column type injury. So column injuries generally go transversely in this plane here, or more of a coronal split. And you can see this exits, the posterior column's involved here, but the anterior column is clean. and we don't see anything exiting forward. Again, admittedly, this is one slide, but the thing to take home from this is that transverse lines generally mean that um, these are column injuries where a line going from front to back would be one from a transverse pattern or something similar. The yellow arrow there just shows the nice ding in the head from being dislocated and sitting on the back of the ischium, hopefully not for too long. And now we go to the transverse. Remember I said before the transverse is the only pattern that exits from front to back and goes through both columns on here. How this differentiates from a both column injury is that the dome in this here is still attached to the axial skeleton. So really a both column is essentially the same fracture pattern, potentially just raised up more cephalad to detach everything there. This is a very common pattern you'll see as well. Not as common as a transverse posterior wall in combination, but it is still common. This has been tested multiple times on the site as well as in training, and so another good one to know. So we can see our anterior column here is involved with our iliopectineal line, and even this without getting any Judaes, you can see this exiting. Our ischium is down here below. You can see this exiting posteriorly into the ischium. So by that alone, I know two columns are involved. Here is a grainy traditional trauma view showing what appears to be the dome shown by the green arrow. The head is medialized, and then really both columns are shifted way medially. The only way to have this happen and still have the dome attached here without seeing a CT, if there's any other wall involvement, would be a transverse pattern here. There's no involvement of our inferior rami that would make us think it was a T-type fracture. So this is one actually from a question on our site that shows that this is probably a transverse pattern. In real life, you're going to probably order a CT, and some of the newer questions will have all the cuts. But other than that, you probably want to try to answer the best you can with just the limited data you have on these. So transverse, we can see the fracture line going from front to back. If you remember, the other ones were essentially straight across, so more transverse on a coronal film here. The patient size is the size I see here, unfortunately. But again, a transverse pattern is a front to back on an axial CT. If you see that both columns are going to be involved, now you just have to figure out which of the fracture patterns with both columns it's going to be. So again, you see we keep bringing this up, and that's because this is important. You need to know these here. The both column, again, this is probably testable. You see more than you will in real life, hopefully. The big thing with this, remember the definition, which is the axial skeleton is not attached to the acetabulum. So the green arrow again shows where this is incorrect, and the fracture line needs to be above this piece here. So this would not be a both column fracture. The spur sign is another thing that's been tested actually several times, not over the last couple years, at least on in training, but has been lit up with questions previously here. So on this AP pelvis, we see that the posterior column on the patient's right is involved. Again, I start from top down, so I see this fracture line here first, closer to the notch. This is medialized and rotated in, and then our anterior column, as we follow up our iliopectineal line from the front here, does not look like the other side. So everything is kind of comes up here, and there's a big jump back over to the rest of the iliopectineal line. So both columns are involved here, we know for sure, but with this here, if you just look at the dome, it may look like some of this may be attached. So that's why we get more imaging. They are nice enough to draw a yellow arrow up, so even if you can't see the fracture line going up there, you can see the asymmetry of the posterior and more anterior iliac wing, where this anterior part is shifted more cephalad. So obviously there's a fracture line going up there, we just don't know where yet. We continue to get our views, and here we see the spur sign. So they may ask what the definition of this is or what this is involved with, and that's this particular fracture type. Spur sign is the most inferior part of the intact ilium, so it means it's right above where everything is fractured off of there, and so it's actually the spur sign is the intact ilium. They've asked that before. And then you can see the rest of the pattern can be really whatever, as long as this criteria is met where the axial skeleton is not attached to the acetabulum. The rest of our images here show all the posterior column disruption, which looks fairly severe. So now we have a 27-year-old male who falls off a bicycle high speed, taken to the ER, diagnosed with an acetabular fracture. Which of the following image sets accurately depicts a fracture that involves only one of the two columns of the acetabulum? So this question is nice because you don't really have to define anything. We just have to look for something that just hurt one side. In real life, you may be able to zoom these up, maybe not. So if you can rule any of these out right away, just try to do that and go forward. So try to draw again here, my lovely green arrow. We can see figure A has a fracture line on the anterior column. You can see here on all of these images you can't always tell what's going on with every little part, but we can see an anterior column fracture line, and then I can see a posterior column fracture line here on the 3D image. So if that involves the anterior and posterior column, it can't really be it. So we go to figure B, which now I can see interruption of anterior here and posterior here, which to me, if it goes transversely off this from front to back, it's more than likely a transverse pattern. As we look over here, we can see it going across both columns on the CD, or CT rather. And then figure E, we have a little bit of the same. We've got going from front to back, which probably means both columns are involved. Let's see, I can't even read what figure that is, but the next one involves fracture lines there. We don't see anything exiting into the iliac wing. I don't see anything going into the foramen down below. Looking for a T-type fracture, we can see fracture lines coming out the front as well as a displaced posterior wall fracture. And then figure D, you can see again, it cuts off a little bit of the anterior. How about that? We've got a fracture line in the medial aspect as well as the posterior most aspect of the wall. We don't know if this is part of a transverse or what it may be, so we look at our our 3D CT, which we've rotated for you there, and you can see this posterior column is involved, and our anterior column from this looks pretty intact, so that matches up with our CT. And if we go back to figure D, we can double check this, look at our iliopectineal line, look at our anterior column as it's sliding up here. And I don't see any fracture lines on there. I may be blind, but that's going to be my guess. So figure D. Hopefully that was correct. 41% of you guys got this correct. This is a little bit trickier one, but just going through, if you can rule out some of these, obviously it's a lot easier to have good luck if you can pick between 2 or 3 rather than all 5. So the reason why this one is correct, again, you can see the anterior column is not involved on any of these images here, so even if you're not sure on the other ones, you know for sure this is not involved, so it should be a good one. So T-type we have mentioned, we'll get into that in a little bit. And next one here is posterior column with posterior wall. This is, remember, transverse is the only simple type that involves both columns. The posterior column, posterior wall is the only fracture that doesn't involve both columns in the associated types. This is a common pattern you'll see, and sometimes the posterior wall and posterior column are widely displaced, other times they're not. So the posterior wall is drawn in red there, is fractured off. The posterior wall injury, again, usually from an axial loading posteriorly, but the energy is just through in the leg that's more abducted. So I don't even have to draw arrows. They were nice enough to do that there. So this one here actually looks more like a transverse posterior wall to me. So let's see, with that kind of front to back pattern there, we can see the exit of this little piece here. This piece here, the in-training has got us before on this, before looking at the posterior wall fragment. If you look, in the transverse line is exiting from front to back, and this is essentially just the transverse part where it exits. So it may not be a particular posterior wall fracture. It's a great one to trick people on if you have the whole series here. So let's pretend this is what it is. This little piece probably is from where the exit is here, so this actually may be just a pure transverse. The CT here, or excuse me, the image drawn by the artist actually more, I guess, adequately shows this here. We can see the transverse pattern with the posterior wall fracture, which again is very common and you'll see over and over throughout all of these here. T-shape is like a transverse pattern. It's in the transverse family. We still have the dome attached to the axial skeleton, but you can see the vertical limb in this image that exits out and exits down through our rami region here. The thing that's not fun about these is that the posterior and anterior pieces move independently of each other. So if we reduce one, we may not be able to reduce the other one just by moving and pulling from one side. So you may need two approaches simultaneously, one right after the other sequential, or you may need an extended approach for this here. Here's a figure here finally showing the T-type on a regular radiograph here. We see a transverse pattern coming across the acetabulum. We can see a shadow here looking through the fracture of the posterior column, again a little bit higher, and as you follow this down we can see the exit of the transverse limb of that fracture pattern. This does exit down into our obturator ring down here, so on a test in real life, if you see a transverse pattern, don't see anything else, the next thing you should look at is your obturator ring just to see if this is a T-type. Even on the CT, scan through that and see if it is or is not. So here again you can see if you just get this particular cut, this one looks like a transverse pattern, so it exits from front to back, and really in that family it's just where it exits inferiorly here. So if you see this, don't just reflexively hit it. Your next step after seeing a transverse is to look at the rami and see if that'll help out. Now we have our anterior column, posterior hemitransverse. The fracture line the artist drew here again exits below our ASIS. Some of the things you see on this, it actually exits quite a bit higher up into the iliac wing here. So if we see it up that high, don't be scared. It's just where that anterior column exits here. We have our posterior column involvement, so it's posterior hemitransverse, essentially a transverse line. It's still in the transverse family, it just exits anteriorly a little higher. And here you can also see now our fracture of our parasymphyseal or inferior rami that shows this is still almost a T variant as well. So it's a whole family associated with this. If I hear this fracture pattern, this one here is admittedly not that bad compared to a lot of these here. Usually in elderly patients after a fall, just from standing height onto their side, the lateral aspect of the femur drives into the pelvis and causes this particular fracture pattern. Very rare to see this in somebody younger. Now, arrow-wise, we can see the yellow and now my green arrow meeting up. We have fracture all the way up the ilium here. This one exits very high back by the level of the SI joint posteriorly. As it continues to trend down, exits more anterior. Now we're getting just above the dome, and then now on the far right into the dome, and with the anterior column posterior hemitransverse, we see that medialization of the femoral head, the protrusio, and the breakout of that medial wall, and that's what's happening here. Oftentimes this is very dramatic. So on to treatment. Again, if you want to ask your questions on the right, you can keep doing that. We'll go on to the next part. Treatment of these acetabular fractures here can be protected weight bearing for 6 to 8 weeks. Often it's touchdown weight bearing. It's less stress across the hip doing touchdown weight bearing, and this is in a stable pattern. So if they have an exam under anesthesia and the test is asking you if it's stable, then we go on and we can protect their weight bear for 6 to 8 weeks. Isolated anterior column injuries that are stable, however, you can weight bear as tolerated, and there's literature on that. So operative criteria or operative techniques for this would be either ORIF, plates and screws, percutaneous fixation with cannulated screws most commonly, or ORIF with a total hip. And the total hip can be together, or generally with these you want to marry your columns together, provide some stability for your total hip so it'll last longer. What you pick on this depends on a couple things. The factors really are what the fracture is looking like. So you want to match your treatment to the fracture. You want to match your treatment to the patient as well. So elderly patients, something with significant comminution impaction, we know are going to do worse if they have a gull wing sign, which is evidence of impaction along the dome. That's something where we know the head is going to want to settle into an impacted area, especially with poor bone, and more likely to lean to a total hip arthroplasty. Usually on a test here, they're going to be very clear cut on which way you need to go. If it's something that has a significant amount of impaction, or even bone loss, elderly patients, pre-existing arthritis, they're going to show you a lot to push you towards the total with these here, or they may avoid that question altogether. Protected weight bearing in these if they're too sick to undergo surgery, or the fracture pattern is stable or displaced less than 2 millimeters. If they're morbidly obese, going to cause more of a risk to the patient than a help, could be a good reason as well. Or fractures that are presenting more than 3 weeks later, because oftentimes these require multiple approaches or even an extended approach, as well as osteotomies. They're not going to get to that level on any of these tests here. We went over a lot of the reasons why we protect weight bear. The 20% of or less of the posterior wall involvement is important, but again, as it gets close to that area, pick EUA on the test in real life to be able to assess that wall to see if it really is stable or if it really is not as stable as you thought it was based off one static image in time. The bonus with a both column injury here is that it may have secondary congruence, which means the fracture lines that exit above the rim of the superior dome of the acetabulum to disconnect it from the skeleton may mean that the displacement is there, where most of the displacement in the acetabular, actually the cup itself, is pretty minimal. So the dome, there's really no step off. We don't see much impaction. It's almost like a pelvic ring injury just above the acetabulum fracture. And with these, if it does line up out of any traction, so we're not pulling or adjusting anything here, that may be operative, or excuse me, a non-operative indication. Just something, again, you can really only see with the both column injury. The roof arc angles, generally, again, traditionally is 45. Now we have some other measurements as well, but the involvement of the dome is really where we're getting at here. Any weight-bearing dome, the stability and lack of step-off of that is the most important. If you have a CT, remember, it's 10 millimeters, so you just need to figure out how big your cuts are. There's a picture of Joaquin right there. So the technique of this, skeletal traction generally fallen out of favor here. The things to watch for: if it's a posterior fracture, we may want to use posterior hip precautions just to avoid any stress on that area. Toe touch weight bearing, I've mentioned about the importance of that, is that limits the joint reactive forces across your hip by allowing the weight of the foot to rest on the floor, and you're not pulling your abductors against this to hold this up. Multiple times it's been asked as well which position and what movement has caused the most hip stress, and that is rising from a chair on your affected extremity. So the therapist can work with these patients to try to have them use their arms, use their other leg if possible, to help lift up, or even with assist. So next question: prescribing touch weight bearing, which is essentially the weight of the limb, would be appropriate in the following scenario. Being in the acetabular fracture section, hopefully you guys would be able to get this one right. The other ones are incorrect, just because many of these can be weight bearing as tolerated or should be non-weight bearing altogether. 77% of you guys got this right here, and really the toe touch weight bearing is less joint reactive forces across the hip, and this can last, depending on how fast the patient takes to heal, anywhere from 6 to 12 weeks, depending on fracture pattern and patient characteristics. The indications now for surgery generally are the reverse of what you had before. So acute fractures less than 3 weeks. If they're physiologic stable or able to withstand a large surgery like this here, a local infection is good, or not having any infection is good with any orthopedic implants you're putting in. And then pregnancy is not an absolute contraindication to surgical fixation. Sometimes we may alter surgical tactics, trying less x-ray or percutaneous fixation, but it's not an absolute contraindication to any fixation. Go back. The approaches to these, you need to be like a bank robber and go where the money's at. If there's a fracture line exits anteriorly, obviously you can't get it from the back, so we need to go anterior. They haven't asked yet towards which one should you use, a ilioinguinal versus a stapa. Generally they'll have one or the other on there. The posterior approach to Coker-Langenbach is very common and used to access fractures like this one shown here, which is a posterior injury. And then the combined iliofemoral is done fairly rare in most practices, and oftentimes a test question. So we'll go over these here. Again, go where the money's at. Be a bank robber here. You can't get the back from the front and vice versa generally. The amount of displacement on some fractures, like a transverse that involves both columns, may point you towards going towards one or the other. For example, if it's non-displaced on one side and wildly displaced on the other, you probably want to go on that side. Marginal impaction, if you can only access that from the inside or outside of the pelvis, also you need to go where that's at. Associated injuries can help determine this, but usually you still can't get to the back from the front. So if there's associated injuries, you may have to wait a little while or think about different technique to try to get that fixed. The lag screws for any walls help provide any compression. Same for any column fixation having any interfragmentary compression there. The recon plates are the most common here. These are malleable. We can bend these, put these in position. There's not a lot of great pre-contouring you can do on pelvises that are drastically different in size and shape and where you need to put the plates there. Spring plates and essentially mean plates like this here, where the plate is held more medially and then holds the rim or more peripheral aspect of the acetabular wall, generally posterior, just to help. It's areas that you can't get another screw in. It just provides a buttress against any shear or displacement of that force. Cables have also been described, but have not been tested so far. Timing of this is important. Hip dislocations, as we know, we want to get these back in as soon as we can, generally within 12 hours for improved outcomes. With a fracture that's large and posterior, we may need to put them in traction because the posterior wall is too big, and so you keep them reduced by holding them down into place here. Remember, I keep mentioning this 3-week injury, so 2 millimeters displacement, 3 weeks is another number to remember. If we can get to the acetabulum within 3 weeks, it's an easier procedure. Obviously, we have less callus, less soft tissue contracture, and that's really your best shot at any anatomic reconstruction. Our outcomes vary according to how well we do at this. If we can get the acetabulum back into position, if we can get every piece back, if we can get the marginal impaction corrected, the patients will do better than if we leave them with any fracture diastasis or if we leave them with any step-offs here. The best way to look at that, just like looking at it preoperatively, is with a postoperative CT. That's the most accurate way to tell if you're reduced on here, but there's been no studies that have shown that getting the pre-op CT is going to improve, or getting their post-op CT is going to improve their function. It's just the way you can tell whether you're reduced or not here. So even after you fix this, your greatest stress is rising from a seated position here. It occurs in the posterior superior part of the acetabulum, which is often involved. This would be something important both for fracture knowledge as well as total hip knowledge, and may be tested there as well. We already had the question on functional outcomes, what it correlates the most with, and that's the muscle strength and restoration of gait. So the incorrect answer on the previous one was about having a shortened gait, which is incorrect. That's why we didn't list anything else about the gait in that question to make you pick that choice instead. So total hip, we can see one done here. This shows the acetabulum, which has been fixed, and then we have the total hip as well. So again, restoring the relative anatomy of the pelvis and not necessarily the perfect articular congruency is generally needed before we do a total hip on this. This may be acute or this may be as a reconstructive means here. Acutely, often a pre-existing osteopenia that led to the impaction, significant displacement of the fragments, comminution, or pre-existing arthritis would lead you towards doing this acutely here. You may need augments and other adjunct treatments to your acetabulum on the cup side to be able to do these here. So you may or may not see these in practice here. The older we get, remember, you have worse outcomes. So later on, you have a 30% chance of conversion to a total hip if you're over 60 when you have these fractures here. The acetabular side does not have as long survival rate as does a native primary hip, either on the contralateral side in this patient or in, let's say, an age-matched patient. So these areas have a lot of trauma, and it's not just the acetabulum that can lead to failure here, increased infection rate, and so on. So next question, we have a 35-year-old male suffers an anterior column acetabular fracture during an MVC, undergoes percutaneous fixation. Intraoperatively, fluoros obtain an obturator oblique inlet view while placing a supraacetabular screw. Which of the following screw relationships is best evaluated with this view? The best way to look at some of the percutaneous things here are pulling some of the papers on this, looking at how they do it, which views they're getting, and then I would just get a sawbones pelvis, just look at it and play with it and be able to see which views you need to get. It's nice to review during or before a case rather, and then during the case you can apply this and then see which views in particular you need to get. No images on this one. So the obturator oblique is going to look at that anterior or superior edge of the acetabulum here, and you're going to look at between the inner and outer tables of the ilium here. Sometimes with this here, you can imagine a pelvic X-fix in the supraacetabular region here. It's a very similar concept where you're trying to look down the pillar right above the acetabulum in order to get in that good bone here. It's a tougher question. Only 58% of you got it right. We'll have to get an image for that one to kind of help you guys out a little bit. There's multiple articles on this by Starr and others that show the paths of these, which images you need to get, and so on. So here we have a pelvis. Actually, it's a model based off CT that shows a pelvis fixed with a lot of different screws here. Up top here we have our anterior column fracture exiting there with screws across this. We have a plate, and then we have this long screw in the front, which is nice and sexy. So just like femoral nails can be antegrade and retrograde, these screws can be antegrade and retrograde as well. The retrograde, just going backwards, this one here is an antegrade screw because the head is posterior and you're going distally down the rami here across your anterior column here. So here we have some retrograde type screws that hold the iliac wing in place here. Same with the posterior column screws. And this, actually, these are through the plate. This screw here, I have the arrow on going down into some of the posterior column as it exits medially here. If there's a retrograde screw, the head of the screw would be down here in the ischium going in a cephalad direction into the posterior column, generally ending up in the region of where that plate is right there. Again, these a lot are sometimes hard to memorize, but easier to picture in your mind. At least they have been for me. So this image actually goes with the last question. So we're looking at this, our obturator oblique view. You can't necessarily see our obturator foramen, which would be down medial and inferior to the image, but we can see this kind of TP region here right above the acetabulum, and this is the area of good bone we're trying to hit at with a percutaneous screw in the lower anterior column, as well as doing any supraacetabular X-fix pins here. Really, this looks for whether you're between our inner table of the acetabulum, or excuse me, inner table of the ilium, and our outer table of the ilium, which is out here. And then we can get our iliac oblique view to look at whether it's going cephalad or caudad and going towards the sciatic notch or not. The approaches, as we mentioned, can be varied and depending on our fracture pattern here. You can combine two approaches, or you can use an extended approach like the iliofemoral to do this. This whole thing is on our website. You can look at this here. I'm not going to read every word on there. You can go through that to do it, but at least briefly, the anterior approach, the ilioinguinal in particular here, is used for fractures up front here. The corona mortis is a problem with any of the anterior ones, and that's tested. The lateral femoral cutaneous nerve injury is also one that's important, femoral nerve, and you're exposing your femoral vessels, so these obviously are much more at risk here. So the Stop approach is our other anterior approach, and that's at the bottom. More and more, and this is coming out, and this is being used for more fractures and being written about quite a bit more here. The one thing we can think about the stop approach as being indicated is for access to the medial wall, the quadrilateral plate of the acetabulum. It provides access to that as the surgeon's on the other side of the surgical table here. We do need to see the corona mortis as we dissect over to that aspect of the acetabulum. You will find that before you find the medial wall, hopefully. The posterior approach, now we go in from the back, the Coker-Langenbach is indicated for any posterior fracture patterns here. You have more risk of HO as compared to our anterior approach, but not as much as some of our extensile approaches, which have the most. Our sciatic nerve is seen there, so you can injure that with retractors, instruments, and then if you release any of your soft tissues, your short external rotators close to bone, you also have the damage of, or the risk of damaging the posterior blood supply, which will unfortunately lead to ABN of the femoral head. The iliofemoral really is only tested in most centers, and most times, even in many residencies, you may not see this approach during your entire career there. It's the only one approach that can expose both columns at the same time here. It's indicated if fractures have been out for a long time, you need to do osteotomies, as well as transverse or transverse family fractures that have quite a bit of impaction or superior rim involvement, just because you can get at everything here. Again, it's associated with a lot of comorbidity and complication later, including the HO, weakness, and so on.
If you enjoyed this video, please consider leaving a like. We'd love to hear your thoughts and what you'd like to see next in the comments. Don't forget to subscribe to our channel and follow us on social media.